Happy Wednesday, everybody. We're going to have a lecture today on portion of our Chapter 1 step-by-step manual. We're going to be talking about quality improvement organizations, which can be found on page 4 on both 2019 and 2020. And we're also going to be talking about federal registration. I need to double check page numbers. Give me a second. Both found on page 9 of both manuals. And we're going to be talking about Rbrvs, which are resource-based relative value scales. And that's on page 11. So I have a little slideshow that we're going to get through. So I'm going to share my screen, but those are the page numbers that we're going to be working on. So let's talk about Quality Improvement Organization, QIO. So we're going to go ahead and go back to page 4, and you're going to see that listed there. Protecting the quality of care under Medicare. People with Medicare have the right to quality health care. CMS, Centers for Medicare or Medicaid Systems. I think that that's right. Y'all, I'm having a bad day, so. Centers for Medicare and Medicaid Services, yes. Protects Medicare beneficiaries through the work of Medicare QIOs, your quality of care organization, or quality improvement organization, which work directly with healthcare providers to improve the care they deliver. In addition, QIOs provide direct assistance to Medicare beneficiaries when they have concerns about medical quality or believe healthcare services are being discontinued too soon. Where QIOs are focusing. QIOs work to improve the lives of Medicare beneficiaries as they review the quality of care covered by Medicare. They review appeals of certain provider notices about discharge or discontinuation of services, which means they review potential cases of patient dumping. They implement quality improvement activities to address concerns identified in the course of medical record review and assist hospitals in reporting quality data to CMS that help consumers compare hospital performance. There are 2 types of QIOs, beneficiary and family-centered care. It assists beneficiaries directly, quality of care reviews, and filing complaints or appeals. The next is Quality Innovation Network, and this organizes beneficiaries, providers, and community members for improvement initiatives. They're a data-driven approach, and they focus on safety, health, quality, and care coordination. So we're going to watch a little video.
Remember back in 1801, when Americans elected Thomas Jefferson as their 3rd president? Jefferson had a vision for this young country. He wanted to create a system to connect its people together for expanding trade. This vision sparked the funding for the Lewis and Clark expedition. As a result, a new revolutionary transportation system emerged, the American Railroad. Then came the steamboat and the automobile. This innovation in transportation impacted the masses. A new national economy formed. Industries benefited, new communities and cities sprang to life. Innovation requires us to look differently at what's in front of us, and then boldly imagine what's possible. It's about a shift in perspective. It transforms the way we live. When Jefferson made innovation a priority, it improved the nation's quality of life. That's what the QIO program does. It drives innovation and raises the bar for healthcare in our country. How? The QIO program helps define the goals for healthcare quality improvement and creates a shared vision that unites communities nationwide. It takes people, ideas, imagination, and resources, and through the process of continuous learning, data analysis, and open dialogue, the program makes connections by looking at the big picture. When each healthcare provider and community is focused on individual improvement, it can be challenging for communities to work together and make discoveries outside themselves. The QIO program connects the dots to discover breakthroughs that improve the entire system. This drives us toward our goal of improving healthcare for all. For example, in 2006, a special innovation project launched in 3 communities, focusing on improving transitions of care. In 2008, 14 communities joined. Now it involves over 300 communities nationwide and continues to grow. The QIOs work with each community in an innovative and collaborative way. As a result, hospital readmission rates dropped nationwide and nearly $1 billion were saved. What innovations will we identify and spread next? Let's lay the track to continue America's legacy of rapid innovation. Quality health care for our citizens depends on it.
Okay, I really thought that that was a very, very simplistic way to put what a QIO is. And I just thought it was a fun little video. And I think that, you know, when you're visually, let me stop and think about the words I want to use. When you're visually stimulated, your mind really grasps that information. So QIOs are not at all complicated. It's just about the quality of care. So now we're going to talk about something called the Federal Registry. The Federal Registry is published by the Office of the Federal Registrar, National Archives and Record Administration. The Federal Register is an official daily publication for rules, proposed rules, and notices of federal agencies and organizations, as well as executive orders and other presidential documents. So this is what a Federal Registry looks like. And you actually have a picture of that on page 10. It's bigger than this. So when is it published? The Federal Register is updated daily by 6 a.m. and is published Monday through Friday, except for federal holidays. Okay, so I'm sorry, I'm going to go back to that. I want you to actually get on and find the Federal Registry. It's not hard to find. I want you to Google it, and I want you to put under this video that has the lecture on it, I want you to put found the registry and looked at it. It's something that is outstanding. I mean, it's really just amazing to behold how much information's in it. But I just want you to be able to find it. So I'm going to give you that assignment. So here we go. We're going to talk about outpatient resource-based relative value scale, Rbrvs. And they're often referred to as fee schedule or fee for service. Those of you who have been with me for a while will recognize the word fee service. So I'm actually going to do another video, and it's not too long, but it's so important. I want you guys to understand what this is, and this video to me breaks it down very simply. So, or maybe not
here with
simply,
Professor,
but in a
and
very,
salary is a nice incentive in a lot of ways, but requires you to have a big.
Listen to the whole thing, as you can tell. So let me see if I can get this to expand and start from the beginning.
I'm here with Professor Lawrence Baker, who's a professor here at Stanford Medical School. And what are we going to talk about?
Well, we pay physicians a lot of different ways in this country, and I thought it'd be useful to spend a minute thinking about the different ways that we do that, the concepts, organizations, different practices that are out there.
So literally, how do physicians receive their compensation?
Yes.
Okay.
Yes. So we can go through this in a couple of different ways, but there are 3 ways that we can start out talking about, 3 general ways that we organize the payment of physicians, and they turn out to be fee-for-service,
Fee for service. Let me write this. Fee for service. Keep going.
Fee for service.
I'll catch up.
Yeah, sometimes we say FFS, fee for service.
FFS. Okay, makes sense.
The second one we call capitation.
Okay.
And the third one, of course, salary.
Too close to decapitation for me, but maybe it's unrelated. But okay.
It's all over your NCCP.
And then salary.
And then salary.
Okay. And so fee for service, that seems to be a little bit common sense. Is that literally it? Like
fee for service, in a fee for service system, a physician gets paid a fee for every service that they do. It's kind of like going to a restaurant. You know, you order the drink, you order a salad, maybe an entree, a dessert. This restaurant keeps a list of all the things that you ordered, and at the end of the night, there's a price associated with each one, and you add up the price associated with each of the things you got. That makes your total bill. That's the fee for service kind of system.
I see. And so this is kind of what a doctor of private practice would face.
Well, doctors can be paid fee for service in a lot of different arrangements. Okay. So they might be in private practice paid this way. Some physician groups are paid this way, and fee for service concepts come up even in large organizations like the Stanford Medical School, where some people are sometimes paid for their work in the hospital according to
but the general idea is if they're not providing service or if there's a slow day, then they're not going to be making money that day.
Right. Right. The more services they do, the more expensive services they do, the more costly they do, the more revenue that their practice will generate.
I see. And we'll talk later of whether that's a good idea.
Yep. That, of course, that has implications for the way that physicians act and the way that they practice.
So what's capitation? Because I'm not familiar with that.
So capitation, the general idea is to do something quite different than fee for service. The term capitation comes from the Latin per head.
Oh, so it is related to decapitation, literally per head.
Well, we're going to put it back on per head.
Yes.
And so we're going to pay physicians per person that they have in their practice. And the kind of building blocks of a capitation system would be, one, a panel of patients who are assigned to a doctor.
I see.
The doctor might have 1,000 patients for which he or she is responsible. We'll call that group their members, their panel. Sometimes people call it their covered lives. Second piece of a capitation arrangement is an agreement about what the physician is going to be responsible for under the agreement. So we might say it's primary care services, all the office visits and basic tests and follow-ups that those patients might need, but maybe not their hospitalizations or their expensive surgeries and things like that. So you have some group of patients, you have some agreed set of services, and then you define a payment, which in the jargon gets called the PMPM, the per member per month.
Per member per month. And who is making this payment? It is the employer of the doctor. So this definitely would not be the case with a. Oh, go ahead.
So it would be the insurance company generally that's going to pay the doctor this payment. So if an insurance company, let's say Blue Shield, Blue Cross, Aetna, Cigna, any number of different companies that might be out there, has an arrangement with a physician that they take some number of their insured people are seen by and become part of the panel of that doctor, they could arrange to pay that doctor on a capitation basis.
I see.
By saying, you've got 1,000 of our patients, here's what we're going to pay you to take care of them.
I see. And it seems to make a lot of sense for the insurance company because now you don't have this incentive for the doctor to...
You change the way the whole incentive works. So now if a physician gets, say, $25 per member per month for taking care of their 1,000 patients, they get $25,000 a month. They've got to do what needs to be done for those patients, but they don't get paid extra if they do something additional. If they do a more expensive test as opposed to a cheaper test, they get paid the same amount. And so you take away the incentive that exists in a fee-for-service system that tends to get people to try to do more things, or at least creates a world in which it's possible to do more things and get paid for it.
Right.
And you replace it with a different.
It's more predictable for the doctor, too.
Well, it could be predictable for the doctor, although in some sense it's predictable, and in another sense it's not. An important difference between fee-for-service and capitation, we'll say in health policy, is associated with risk, or this concept of risk. And when we talk about risk here, we mean financial risk associated with the health of the patients or variations in the needs of the patients in a given month. So if you're a fee-for-service, if you're being paid fee-for-service, the doctor doesn't face any real risk. If it's a bad month, everybody's sick, everybody needs lots of care, they're going to get paid for delivering that care.
Right.
Under capitation, the doctor does face more of that risk. They're getting paid a fixed amount. They've got to deal with whatever the patients need.
In a high-volume month, the doctor takes the hit in capitation, but in a low-volume month, the insurance company takes the hit. So it goes both ways. It kind of evens out.
Right. The insurance company, the doctor benefits in the low-volume.
Yes,
right?
exactly.
The doctor kind of averages out. If in a good arrangement, this will be sort of even over time. The doctors will come out okay. But these risk issues have been problems in some capitation arrangements, especially if you're a small doctor practice and you got a lot of variation from month to month. Maybe you're not a great manager. You can go out of business if you have a few bad months.
Who decides that it will be capitation or is it the doctor's choice, or the insurance company says this? No, you will do this.
So over time, it's been a bit of negotiation back and
Right.
forth. So insurance companies have preferences about how they do this, and doctors have preferences about how this happens. And so sometimes some of it's driven just by history. The Medicare program, for example, got started in the 1960s when fee-for-service was the most common way for
Right.
physicians to be paid, and that's largely persisted in that program for historical reasons. It's
Right.
just worked out that way. In the 1990s, a lot of health plans decided, the insurance companies decided that in the private market they'd like to do more capitation, so
Right.
they did. And they started pushing these arrangements, trying to get physicians to agree. They were successful for a while, and then lately it's been a little more physicians have said, we don't like capitation so well, we'd rather go back to fee-for-service, that's working better. So the negotiation has gone a little more the other way lately.
Have there been studies that showed when doctors who are compensated under capitation don't order as many services or perform as many services?
So the literature on this is pretty clear that it makes a difference. We like to think that it doesn't make a difference.
The doctors, right.
Doctors.
Most of them are all about the health of the patient, but
that's the thing, right? So there are hundreds of thousands of doctors in the country,
Right.
and undoubtedly out there are some that pay close attention to the financials. But I think actually you're right. Most of them probably don't, on a day-to-day basis, pay close attention. At the end of the year, they'll see the financials from their practice. Maybe they'll think it through.
But if you got to pay the college tuition, then all of a sudden, hey, maybe an MRI wouldn't hurt, or a little extra this or that.
I think that's part of it. But the other thing that I think is going on in the background is the general, maybe almost subtle, but things that you don't notice that create a system and let a system evolve in a particular way. So doctors like to do things for their patients. Patients like to have things done for them. A fee-for-service system creates a world in which everybody is fine with that. You can do that. And so pretty soon you get used to doing that, and it just becomes the first thing you think of to do these extra things.
Right. Neither party, neither the doctor nor the patient, has any incentive really of saying, wait, who's paying for that? Oh, no, someone else is. Okay.
It's fine.
Right.
And it creates in the background these incentives for people who develop new products and services to develop them, and it makes it easy for a hospital, say, to put in a big new piece of equipment that they're pretty sure they can pay for, and once it's sitting there and you pass it every morning on your way into the hospital, it just becomes that much easier to use it. And so it sort of guides our system, the evolution of our system, in a way that has led us to a point now where we consume a lot of healthcare. Maybe sometimes healthcare that we don't need. It's often healthcare that's beneficial, but it's all costly, and so that sets us up for the kind of dynamics and the challenges we have to face.
How common is I guess maybe we should talk about salary before we talk about how common they are.
We can pick that up as we go along. Fee-for-service and capitation have been ebbing and flowing. Frankly, in the U.S. at the moment, fee-for-service is a very common way for people to be paid, and capitation is declining. There are still
So this is so even though fee-for-service was where everyone started, capitation kind of went a little bit in vogue, and then no one's really a fan of it.
Right.
Or the doctors aren't a fan of it.
Picked up. The doctors were less of a fan, and so the arrangements have been shifting more toward insurance arrangements that would use more fee-for-service these days. So the U.S. is definitely, I think, majority fee-for-service.
Who decides what the panel? Because it sounded like the insurance companies would pay for part of the panel of a doctor would be under capitation.
So these kinds of arrangements can, in practice, get kind of complicated to sort out. The concept of paying per head is clear, but there will be variations that go on. So if you change the scope of services, you change the arrangement. If you have a primary care arrangement for capitation, that's one piece, but of course it leaves off the MRI or the surgery. And what would happen in those cases is a health plan would have an arrangement for primary care services with some doctors under capitation. Then they'd have other arrangements with other doctors. They might, say, have a capitated arrangement with some cardiologists to do the cardiology, or they might have an arrangement with some cardiologists to pay fee-for-service to those cardiologists.
I see. So it's a big mixed up, but obviously there's an incentive. If you are being paid capitation, you want the healthiest people in that capitation panel.
So there's another incentive that's in the background that's a selection kind of incentive, and so it's again a thing where I think doctors probably don't think about this. Most doctors on a day-to-day basis, but it's a
okay. So I'm going to go ahead and move on because I think that you get the gist of that. If you want to find out more about that, this is just youtube.com, and it's Khan, Khan Academy. And you can put in healthcare systems, you can put in billing and coding. They have a ton of different things out there. Okay, so conversion factor. Okay, we're going to talk about the conversion factor, just the information. You're not going to actually understand the conversion factor until you get to your facility and you begin, if that's part of your job description. So we're just going to get into the facts about it. So conversion factor, or CF, is a national dollar amount that is applied to all services paid on a basis of the Medicare fee schedule. Congress provided a CF to be used to convert RVUSs to dollars, updated annually on the basis of the data sources. The CF indicates the percent changes in the Medicare Economic Index, percent changes in the physician expenditures, relationship of the expenditures to volume performances standards, change in access and quality. The CF varies according to the type of service provided, medical, surgical, or non-surgical. Okay, we're going to talk about Medicare fraud and abuse. Program established by Medicare to decrease fraud and abuse. Fraud is intentional deception to benefit, for example, submitting for services not provided. Okay, we're going to talk about beneficiary signatures. Beneficiary signatures on file, service charges submitted without need for the patient's signature, because that's why you have it on file. And this presents an opportunity for fraud. Fraud. Anyone who submits for Medicare services can be a violator. Physicians, hospitals, laboratories, billing services, you. You cannot intentionally commit fraud, guys. You have to be above board. Fraud can be billing for services not provided, misrepresenting diagnoses, kickbacks, unbundling services, falsifying medical necessity, and routine waiver of copayment. Okay, OIG, Office of Inspector General, develops and releases a monthly work plan, outlines monitoring for Medicare programs. MACs monitor those areas identified in the plan. So if you know that your practice is committing fraud, after you take all the steps of speaking, gathering your information, going to the office manager, trying to make those changes, your next step would be the Office of Inspector General. Complaints of fraud submitted orally or in writing to MACs are the OIG. Allegations made by anyone against anyone. Allegation followed up by MACs and are the OIG. So abuse generally involves impropriety, lack of medical necessity for services reported, and the review takes place after a claim is submitted. May go back and do historic review of the claims. Okay, what are kickbacks? Bribe or rebate for referring patient for any service covered by Medicare. Any personal gain equals a kickback. It's a felony. You can have a fine, jail, or both. Protect yourself. Use common sense. Submit only truthful and accurate claims. If you are unsure about charges, check with the physician or your supervisor. Okay, so we have one more little thing. Please make note of this law. It's a must know, and it's very short, I promise.
This is our anesthesia compliance tip brought to you by Anesthesia Compliance Consultant. Your tip for today is on the anti-kickback statute. The anti-kickback statute is a criminal law that prohibits the knowing and willful payment or remuneration to induce or reward patient referrals or the generation of business involving any items or service payable by the federal healthcare programs. Remuneration includes anything of value and can take many forms besides cash, such as free rent, expensive hotel stays and meals, and excessive compensation from medical directorships or consultancies. Criminal penalties and administrative sanctions for violating the anti-kickback statute includes fines, jail terms, and exclusion from the participation in federal health care programs. Under this law, physicians who pay or accept kickbacks also face penalties of up to $50,000 per kickback, plus 3 times the amount of the remuneration. As a physician or provider, you are an attractive target for kickback schemes because you can be a source of referrals for fellow physicians or other healthcare providers and suppliers. You decide what drugs your patients use, which specialists they see, and what healthcare services and supplies they receive. Just as it is illegal for you to take money from providers and suppliers in return for the referral of your Medicare and Medicaid patients, it is illegal for you to pay others to refer their Medicare and Medicaid patients to you. Contact us for more information on these important topics and
Okay, so that's the anti-kickback law. If you didn't quite understand what it means, I want for you to go out yourself and know what the anti-kickback law means. These laws are all over your NCCT, and we will be going over them regularly. But this is my first assignment for a law for you. I want you to get out there, and I want you to know what the anti-kickback law is. Find it in the simplest forms you can find it, and we will be talking about it tomorrow. I'm sorry that your lessons are late today. Complete transparency. I had a bad day yesterday and I thought I put them in and I did not. So I'm going to convert this video and put it in, and then your lessons will follow. Guys, have a wonderful day. Remember, we have a Zoom live at 10 o'clock tomorrow, and we're going to be talking about the HIPAA law, HIPAA training. I put up some information for you to be reading, and I want you to pay attention to the questions that are there. Matter of fact, write down those questions or write down the answers to those questions, because that's what we're going to be discussing tomorrow together. I hope you have a great day. If you need anything, please reach out and let me know. Bye-bye, guys.